We are live, please.
A very good evening to all of you. Today we are on this AIR's webinar, Walk-in Patient with Subluxated Lens. We have with us our chairperson, Dr. Brigadier Sanjay Mishra sir, and Professor Tityal could not join because he is in between traveling. And I'll be moderating the session. We have our expert panel who will give us their invaluable inputs, Dr. Rama, Dr. Vijay, and Dr. Sridevi Nair. And we have our presenters, Dr. Jayanand Gure, Dr. Rimil, and Dr. Sivi. I request our chairperson, Brigadier Sanjay Mishra sir, to please officially start the webinar and give his invaluable inputs.
Thank you, Manpreet. It's a wonderful opportunity to be part of this very, very important topic. We face every day or maybe once a week. It's very important, especially in our texts, when we are having a lot of trauma cases, and when we see these cases, it initially for a young surgeon to see a subluxated lens with a cataract, there's a sense of, tension in this. How do you manage it? So we have various settings of subluxated lens, whether it is traumatic, whether it is congenital. So many situations are there which can result in a subluxated lens. We have a very expert panel who will be discussing on the various, situations of a subluxated lens. But I'm sure at the end of the session, we'll be able to see and manage how well we can manage in all settings. But one sincere advice from my side, that whenever you see, please examine your patients carefully before taking them to operation theater with undilated and dilated, because we are not only looking at the subluxated lens, we have to also look in the posterior segment, because if a traumatic trauma comes and you have a subluxated lens, invariably you may have kind of a vitreous hemorrhage, or you may have some kind of retinal tear or dialysis. So that has to be also very, very important to manage those cases. So focus your patients in toto and manage accordingly. As far as, you have a subluxated lens in a cataractous situation. So again, that has to be managed in various various manners. So that will also be discussed, that how we are. So at the end, I'm sure we'll be all learning and sharing the experience that how well we can manage these cases. So Manpreet, over to you.
Thank you so much, sir. I think one very pertinent point you brought is pre-op examination. Often we are dealing with this subluxation on table because we miss them due to a lack of careful examination. So that is very important message. So we start with a series of case presentations. The first case will be a case of ectopia lentis with intralenticular lens aspiration plus scleral fixated intraocular lens by Dr. Siri. Dr. Siri, can you please share your presentation?
Yes, ma'am. Can you see the presentation, everyone? Is my presentation visible?
Yes, it's visible. Can you minimize all the download screen? Yeah, now it's okay.
Yes,
You
ma'am.
can go to the slideshow mode. Yes.
Yes, ma'am. Good evening, everyone. Today I'll be discussing about intralenticular lens aspiration with scleral fixated intraocular lens. Coming to the brief history, we had a 6-year-old female patient with chief complaints of decreased vision in both eyes since 1 year. She was evaluated at a local eye hospital and diagnosed with Marfan syndrome. There was a positive family history of Marfan syndrome in the father. On systemic evaluation, her height was increased for the age. There was increased arm span to height ratio. There was decreased upper segment to lower segment ratio. High arched palate was present. Thumb sign and wrist sign were positive. 2D echocardiography showed aortic root dilatation and mitral valve regurgitation. So on ocular examination, her uncorrected visual acuity in the right eye was 1/60 and left eye 2/60. Near vision in both eyes were N36. On cycloplegic refraction, in the phakic zone, there was high lenticular myopia with astigmatism. On slit lamp evaluation, there was superior nasal subluxation from 4 to 10 o'clock of around 7 o'clock hours in the right eye, and temporal subluxation from 5 to 1 o'clock of around 8 o'clock hours. Fundus evaluation revealed myopic changes with tessellations. So diagnosis of Marfan syndrome with both the ectopia lentis based on the revised Giant's nosology was made. She underwent right eye followed by left eye intralenticular lens aspiration plus glued intrascleral fixated intraocular lens under general anesthesia. So here's a surgical video. So the limbus was marked at the 3 o'clock and 9 o'clock position using the Mendes ring. Localized temporal and nasal conjunctival peritomies were performed. Meticulous cautery was performed after that to achieve adequate hemostasis. The sclera was marked 2 mm posterior to the limbus at 3 o'clock and 9 o'clock positions using a GB pain marker. Partial thickness scleral flaps were outlined and fashioned with the help of a blade breaker and a crescent blade, with the leading edge of the crescent blade visible throughout the dissection to prevent any inadvertent scleral perforation. The flaps were completed using angled Vanna scissors. 2 MVR entries were created, followed by 2 stab incisions in the anterior capsule of the subluxated lens, one serving as the irrigation port and the other as the aspiration port. The irrigation port here served a dual purpose, stabilizing and centrating the subluxated capsular bag, along with the hydrating the lenticular matter to facilitate aspiration. A controlled intralenticular lens aspiration was performed while preserving the capsular bag and the posterior capsule. The emptied capsular bag was removed using a vitrectomy cutter. Limited anterior vitrectomy was performed after that. Sclerotomies were created 2 mm posterior to the limbus at the pre-marked 3 o'clock and 9 o'clock position. A 3.2 clear corneal incision was made. A foldable 3-piece intraocular lens was injected into the anterior chamber. During the injection, the leading haptic was grasped using 23 gauge max grip esophageal forceps through the nasal sclerotomy and externalized. The trailing haptic was subsequently externalized through the temporal sclerotomy using the handshake technique. Main port was sutured with 10-0 monofilament nylon, followed by tucking of the haptics into respective scleral tunnels. The scleral flaps were secured using the fibrin glue. Conjunctival peritomy flaps were repositioned with the fibrin glue. The surgery was concluded after confirming a well-centered glued esophageal and watertight wound closure. So understanding ectopial lentus, it is a partial displacement of natural crystalline lens from its normal position in the patellar fossa. Etiology can be broadly divided into 5 major groups. One is isolated ocular anomalies associated with systemic syndromes like Marfan syndrome, Weil-Marchesani, associated with metabolic disorders like homocystinuria, hyperlysinemia. Ocular conditions leading to ectopial lentus are congenital aniridia, ectopial lentus at pupillae, high myopia, hypermature cataract, pseudoexfoliation, other common causes being surgery and trauma. So there are certain indications for surgery. Subluxated lens bisecting the pupil, leading to phakic and aphakic zone in an undilated pupillary axis. Visually significant and progressive subluxation leading to high lenticular myopia with irregular astigmatism that cannot be treated by conventional means such as glasses or contact lenses. Risk of anterior or posterior subluxation, lens-induced glaucoma, significant cataract. So intralenticular lens aspiration as a surgical modality was first described in 2005 in RP Center for Ophthalmic Sciences, where they performed this technique in 10 eyes of 5 patients. So initially when they described, they made 2 small circular anterior capsular access, followed by bimanual irrigation and aspiration. The bag was left intact to allow it to fibrose so that secondary IOL could be planned. So this technique was effective and safe in extensively dislocated crystalline lens in Marfan syndrome. So the advantages of this technique, that is intralenticular lens aspiration or conventional lensectomy, is that the lens is stabilized by the irrigation cannula within the capsular bag. So there are minimal vitreous disturbance, reducing the need for vitrectomy. There is controlled aspiration within the capsular bag, minimizing the lens drop into the vitreous cavity. It's a closed chamber technique. It maintains excellent anterior chamber stability. The corneal incisions are small, so there is less induction of astigmatism. There is reduced trauma to the corneal endothelium, iris, and other intraocular structures. Another study was conducted in 2025 in RP Center for Ophthalmic Sciences, where they evaluated the outcomes of intralenticular lens aspiration with glued scleral fixated intraocular lens for ectopial lentus and Marfan syndrome in 44 eyes of 25 patients. They observed that there was significant improvement in the visual acuity and there was good refractive outcomes. So the most commonly observed complications were vitreous hemorrhage and transient hypotony, which eventually are resolved. Another observation that they made was younger age of presentation was associated with poor postoperative visual outcomes. Now, coming to rationale of esophile in ectopia lentis, there are certain limitations of capsular bag fixation in such conditions because one is there is extensive zonular dialysis. Even if that zonular dialysis is limited, it is a progressive condition. Eventually, it compromises the long-term capsular support. Now, what are the advantages of scleral fixated intraocular lens over other secondary IOLs? First thing is it maintains the intraocular lens in the physiological posterior chamber position. It reduces the endothelial cell loss and risk of long-term corneal decompensation that would be seen in anterior chamber IOL. It avoids iris-related complications like pigment dispersion, chronic inflammation, pupil distortion, and disinclination that are encountered in iris claw IOLs. So it can be combined with intralenticular lens aspiration as a single-stage procedure for complete visual rehabilitation. This is some of the evidence supporting the esophile in ectopia lentis. Most of the studies showed significant improvement in the best corrected visual acuity and postoperative refractive outcomes with stable IOL fixation. So some of the most commonly observed complications are again vitreous hemorrhage, transient hypotony. Very few cases showed haptic extrusion, posterior dislocation. So esophile can be performed safely with very rare serious vision threatening complications. So the esophile also has evolved from sutured to sutureless. The sutured esophile, although has longest clinical experience and it's technically less demanding, but it is associated with disadvantages like there is risk of suture degradation, erosion, exposure, leading to late haptic IOL decentration or dislocation due to suture failure. Also, the surgical time required is longer. Sutureless esophile has been most commonly performed techniques of esophile in the recent years because there is no suture-related complications and better long-term IOL stability without any suture degradation. But this learning curve is steeper, and the haptic-related complications like haptic exposure, slippage, extrusion can still occur if the flaps or tunnels are not created properly. So lastly, discussing the special considerations for pediatric esophile in Marfan syndrome. The sclera in them is thin and fragile because of mutation in the fibrillin 1. So there are high chance of scleral perforation during flap creation or tunnel creation. One has to be careful. High axial myopia will lead to scleral thinning and globe enlargement. So gentle needle and haptic manipulation is essential to minimize the vitreoretinal traction. The routine 1.5 mm to 2 mm posterior limbal fixation may not accurately correspond to the ciliary sulcus. So modify the fixation sites according to the axial length and ocular anatomy. Large wide-to-wide corneal diameter may increase the haptic stretch and IOL tension. So adjust the fixation points to achieve optimal centration and reduce the haptic stress. Increased retinal risk due to high myopia and Marfan syndrome. They have predisposition to retinal tears and retinal detachments. Perform meticulous peripheral retinal examination and ensure lifelong retinal surveillance. Pediatric considerations are like there is ongoing ocular growth that could lead to myopic shift and refractive changes. So long-term follow-up is required in them. Thank you.
Thank you, Dr. Siri, for a wonderful presentation. She's our senior resident, and I think she has taken a case presentation and expert opinion on the surgery all in one. So let me ask my experts now. Sanjay Mishra sir, we'll start with you. What would you prefer when there is extreme subluxation, which is on the borderline of maybe an intracapsular extraction or doing an intralenticular? What would you prefer, doing an intralenticular lens aspiration, or maybe let do a lensectomy, or let a posterior segment surgeon tackle in the extremes of cases?
So, Preet, this is a very important question, but you must understand the context of this situation. So these are cases of a congenital disorder. So I said that as congenital disorders, there is a zonal problem. You know, if you put a segment or you put a CTR, over the period of time, it's not going to be a stable bag. So eventually this bag is going to fall down. So you have to have lens aspiration and do a scleral fixated lens. There is no other choice other than that. As far as being both the cataract and retina surgeon, what technique has been done is a correct technique, because normally people tend to take a cutter, just as do it a cutter and remove the entire lensectomy. But you see what happens, that when you do that, you may have some fragment of lens which is going down. That will force you to do a complete vitrectomy. Then you don't want some element of cortical matter lying behind and causing inflammation in child. So one part. Secondly, I wanted to ask Siri that, Siri, you have made a scleral flap,
Yes, sir.
one at 1 mm and then again at 1 mm. What is the reason behind that? Not make a complete 2 mm flap and then going there.
Sir, basically, initially we marked the scleral flap 2 mm from the limbus. The remaining marks were made to outline the scleral flap diameters, which we make slightly bigger. So it was between 1.5 to 2 mm. The mark that I made was from the limbus. That was for the entry. The entry is actually 2 mm. The remaining outline marks were for the scleral flaps.
Okay. Okay. So that's
Uh,
where this message has to go down to all our young ophthalmologists who are wanting and who are learning to do scleral flap. This is very important because if you make a sclerotomy lesser than that, then you are likely to hit the root of the iris and you can cause a lot of bleeding, and then sometimes you have to abandon the surgery. So that's very, very important. And how do you do a sclerotomy is again very, very important, that your knife has to be pointing towards the mid-vitreous cavity. It cannot be parallel, because again, if you're going parallel, you will touch the root of the iris and then again cause a bleeding. So that's a good technique what you have done. I wanted to elaborate on that because that's a correct way of approaching this case.
Thank you, sir. I think
Thank you,
your
sir.
retina experience in this adds a unique perspective, because we anterior segment surgeons tend not to respect the vitreous as much as you do. So the message here is that do respect the vitreous and do an intralenticular lens aspiration and do neat sclerotomies at the appropriate distance. Rama sir, I would like your opinion. As sir said that he would not prefer, since it's a progressive zonulopathy, he would not prefer fixation. But we do have in literature double CONE people have done, or a capsular tension ring CONE modified CTR along with a capsular tension segment. So, do you have any experience with us? Because our experience tallies Sanjay sir's experience, that we also prefer an intralenticular lens aspiration with scleral fixated IOL. Any experience in the younger patient with maybe a double fixation of the bag?
No, actually, I have seen people operating with that, but I myself, being a vitreoretinal surgeon, even I have this propensity to go for a proper vitrectomy. Even most of the times, I prefer going for, especially in these cases with Marfan syndrome and with pathological myopia and vitreous being disturbed. So I prefer going for a proper pars plana vitrectomy also. So I have seen people doing this double fixation of the bag and putting the intracapsular IOL fixation, but somehow these kind of eyes, they don't do well over long term. I remember, like as a resident at RPC, my first case presentation under Dr. Khoker sir was a Marfan syndrome case with a subluxated lens and a scleral fixated IOL. No, not it was not a scleral fixated. Actually, that was. Intra capsular like in the back fixation of the IOL, and by the time I reached my third year of residency, we saw the child developing a dislocation in one of the eyes. Both eyes were operated. That was not just one case, but it is a high possibility that it can happen. So I personally don't prefer going for fixation of the bag at all. Definitely intralenticular aspiration and then going for this. But I don't know, somehow the way I practice, I prefer whenever you are disturbing the vitreous and when you are taking especially children on table, that too with systemic risk factors, better to be more aggressive on the vitreous part. I prefer doing entire pars plana vitrectomy and then going for fixation of the IOL.
Okay, sir. So one more thing, like in these cases, the incidence of giant retinal tears, dialysis, by virtue of the Marfan's itself and a high myopia itself, and then by virtue of the procedure, the scleral
Yes.
fixated lens and disturbing the vitreous, is higher
Yes.
than normal. So in your experience, how is it different from doing a maybe routine SFIL or a routine subluxated in some other case vis-a-vis a Marfan's in which you end up doing an illa SFIL?
That's what any subluxation, maybe a post trauma in a normal eye. I may not think about going for an entire pars plana vitrectomy without any dialysis or any other lesion over there on the retina. But these cases where the myopic eyes and having a pathological vitreous, I prefer to be more safe than sorry afterwards. So
Okay,
I
sir.
prefer going for entire proper
Pars
vitreoretinal
plana.
surgery with the entire vitrectomy, pars plana vitrectomy, and then fixing the IOL.
Okay.
And I think, I don't know, long-term experience of many of these iris fixations are also coming up nowadays. I think it is definitely a good alternative to, like in her presentation, she mentioned uh, faster surgery in experienced hands and better results and all these points for in favor of a glued scleral fixated IOL. But even posterior iris claw fixation also is a good choice. The only problem is not many surgeons are doing, and not much of an experience from many. I think that is a good option even in children, because I have done quite a number of cases, and they're doing well over a period of follow-up of more than 5 years. So I think it should be, maybe it may come up later after many people start accepting and doing. So that is also one of the good options.
The only issue in these cases are that if you put a pupil iris fixated lenses, and if these children go on to develop some retinal pathology, maybe then the dilatation is an issue. It doesn't dilate much, and then it's difficult to see the periphery in these cases. So one has to keep that in mind, because these are all, after all, pathological eyes. They are, have to be followed up, long-term follow, because some of them, a lot of cases we see that over a period of time they develop a GRT or they develop a detachment, and then you especially even we've seen like post ICL detachments. You have to remove the IL in these cases also, because pupil is rigid and it cannot dilate, and becomes very difficult to see periphery, especially in a child, because those peripheral shaving is very, very important. Otherwise, you tend to have a redetachment.
Yes, sir.
So
I fully agree with that.
for iris flow, I would also like to say, like, you're attaching the intraocular lens on a dynamic tissue. The pupil is going to be mobile throughout the life, and it's a young child, less than 10 years. So we are looking at a potential lifespan of maybe 70, 80 years further down the line. So is it a given that maybe 20, 30 years down the line, it will fall because of the continuous movement? Because the eyes are, as it is, they have pathological myopia. The sclera is more less elastic because of the marfans, and it also stretches. So is that going to be an issue long term? Is also, I think, we are a bit skeptical about in
That's
advocating
what.
for young children. Yes, sir. And Dr. Vijay, I would like to ask your inputs. Like, you have such a wide experience with intralenticular lens aspiration and scleral fixated in the younger population. So, any issues you face with creating the scleral flaps, sclerotomies? Any tips for the younger generation who are venturing into doing SFIs? How do these pediatric eyes behave differently, and what should we take care of?
Okay, so as far as the age is concerned, so normally we prefer that the child should be around 10 to 12 years of age. That is a safer age. By that time, you come to know that there is not much of scleral thinning, and also by that time, most of the times by the age of say 8 to 10, the patient has a good vision with the spectacle correction as well. So it's better to delay as much as possible as far as the intrascleral haptic fixation is concerned. So normally we prefer that at least child is 8 to 10 years of age, and by that time you are aware about how fast the eye is growing. And the other aspect that we were discussing was that iris claw lenses. Now these, we have seen some patients, if you remember in RPC also, there were many young children who had a bilateral iris claw done earlier, and one was a kabaddi player. These children are physically active in their young adulthood, so they do get a lot of disenclavation of these iris claw lenses, and ultimately that also results in atrophy over a period of time. You have to remove the iris claw lenses and may have to go for intrascleral haptic fixation in these cases. So the choice of technique, maybe a scleral fixated is a better alternative compared to iris claw in younger children. And secondly, yes, as much delay as you can do till the time you are confirmed about the scleral thinning, or how much is the scleral thinning, or is sclera sufficiently thick to allow intrascleral haptic fixation by making a flap. That is also important aspect.
Yes. Dr. Sridevi, a lot of times I think we face the issues that because of these Marfan eyes with elongating axial length, the optic haptic total diameter is not sufficient enough to allow exteriorization of the haptic and a safe tuck which does not slip through. So any modification you would suggest for these cases?
Yes, so we have actually seen in a few of our cases as well, especially the white to white, often goes to 12, 12.5, 13. And now if we go and make a sclerotomy at 2 mm or 1.5 from the limbus in that eye, your total dimension will definitely exceed your 13 mm of the IOL. And in that case, the risk of slippage, especially these are kids, they have, trauma or something, the slightest insult can lead to a slippage. So I feel that maybe we can adopt the Yamane technique in these cases, because in the amount of the haptic that you require for fixation, suddenly it is reduced because you just need to create a bulb. That said, we still don't have a lot of evidence on the long-term outcomes of Yamane, especially these are children that we are talking of. So 10-year, 15-year, we don't know how stable these lenses will be. But considering that, if it is a case where the white to white is more than what is usual, then it might be a good option in these cases to fix the lens.
Thank you. I think we'll move on to the next case. So our take-home message from this case is respect the vitreous. And this is a progressive zonulopathy, so do not play with rings and segment. Now Jayanand is going to tell us when we can play with rings and segments, in which cases. So we have Dr. Jayanand Urukude, who is assistant professor in Triage, Chandigarh, and also an RTC alumni. Over to you, Jayanand.
Thank you, ma'am. Good evening, everyone.
So Jayanand, you have a share tab at the bottom of your screen.
Right, ma'am.
Do you need us to walk you through, or you'll manage?
Please, ma'am.
Do you have the share
Okay.
button on the bottom 6 o'clock? Can you see the share icon on the Zoom screen?
No, sir.
Next to chat, or you have a share button which has an arrow in a box. Did you join through application, or did you join through application? You should have that. Just or look at the 3 dots which says more.
Okay, Dr. Rimil, are you ready? Because we
Yes,
can
ma'am, I'm ready. So
okay,
can
Dr.
I
Rimil,
share
please,
my...
share your PPT. So before we have Jayanand stop, we'll have a varied case presentations by Dr. Rimil. Dr. Rimil, over to you. Jayanand, meanwhile, let's talk.
So I would like to share my screen. Is my screen visible, ma'am?
Yes, Dr. Rimil, it's visible.
So, good evening, everyone. Today, I'll be presenting few cases on different spectrum of subluxation of lens. So, starting with my first case, who's a 40-year-old farmer who presented with complaint of diminution of vision in his right eye since 1 year. So he was apparently asymptomatic 3 years back when he had a history of fall from his scooter, after which he sustained injury to his right eye with the handle of the scooter, had immediate pain, redness, watering, and diminution of vision, for which he consulted a nearby eye clinic. After which his symptoms gradually subsided, but he noticed gradual diminution of vision over a year. His visual symptoms still persisted, for which he presented to our OPD for further evaluation. On ocular examination of his right eye, his unaided visual acuity was 6 by 60 with no further improvement with pinhole. His anterior chamber was irregular in depth and normal in content. Iris showed a iris sphincter tear at 3 o'clock position. The lens showed a rounding at the equatorial region with subluxation from 1 o'clock to 4 o'clock position and a rosette type of a posterior subcapsular cataract. His fundus examination was within normal limit. So the diagnosis made was a post-traumatic cataract with moderate zonular dialysis of the right eye. Now, my second case had similar complaints with progressive diminution of vision in a right eye post blunt trauma, after which she developed progressive diminution of vision associated with complaints of monocular diplopia and glare, for which she consulted the ophthalmologist, and after which her initial complaints was relieved, but her visual complaints were still persisting, for which she presented to us. So on ocular examination of her right eye, her unaided visual acuity was 3 by 60, which was improving to 6 by 60 on pinhole. Her anterior chamber was similar, like anterior irregular in depth and normal in content with no vitreous seen. Iris showed iridogenesis with iris sphincter tear at 3 o'clock and 9 o'clock position. The lens showed a cataract of NO3, NC4, C3, and P4 with phacodonesis and subluxation from 1 o'clock to 9 o'clock position, and her fundus examination was within normal limit. So it was again a case of post-traumatic subluxated lens with severe zonular dialysis of the right eye. So my next case was of a child who presented with a different spectrum of diminution of vision in both his eyes, presented with painless progressive diminution of vision in both her eyes since 5 years, with the difficulty in reading and seeing the blackboard at school, with history of frequent changes of glasses and no history of previous trauma or any eventful antenatal or postnatal period. So, on general examination, the child was thin built with increased arm span compared to his height, with a positive Walker, Mudroch, and Steenberg sign. His cardiac evaluation was within normal limit, and his systemic examination was unremarkable. So, on ocular examination, his unaided visual acuity in the phakic zone was 6 by 60. His retinoscopy showed a double retinoscopic reflex with -9 in the vertical diameter and minus 13 in the horizontal meridian. His best corrected visual acuity was 6 by 16 with -7 spherical and -4 cylinder at 90 degree. And this retinoscopy in the aphakic zone showed +4 +4 spherical in both the meridian. So the best corrected visual acuity achieved was 624 with +2 spherical. His anterior chamber was deep with vitreous strands seen in the A zone of aphakia. His lens subluxation was seen inferionasally with dialysis from 8 to 4 o'clock. Phacodonesis was present with wrinkling of the anterior capsule. His fundus was a tilted disc with myopic crescent. In the left eye, his unaided visual acuity was 6 by 60 with the retinoscopy having a double retinoscopic reflex with -8 in the vertical diameter and -10 in the horizontal meridian. His best corrected visual acuity in the phakic zone was 6 by 18 with -6 spherical and -2 cylinder at 90 degree, and his retinoscopy in the aphakic zone showed +5 in the vertical meridian and +3 in the horizontal meridian. His best corrected visual acuity was 6 by 24 with the +1 spherical and +2 cylinder at 180 degree. So his anterior chamber was deep with vitreous stance. Lens showed subluxation in the temporal region with a zonular dialysis ranging from 6 o'clock to 12 o'clock position. The fundus had a tilted disc with a myopic crescent. So he was a case of Marfan syndrome with bilateral subluxation of lens with severe zonular dialysis. So coming to my last case with a diminution of vision since childhood, right eye examination was within normal limit. The left eye showed an unaided visual acuity of counting finger close to face, improving to 6 by 60. This iris showed an iris coloboma, which was seen inferiorly. Pupil was a keyhole-shaped pupil. Lens had cataractus as NO1, NC1, C2, P4 as per Lockstreet classification with absence of zonules from 5 o'clock to 7 o'clock position. On fundus evaluation, the optic disc was horizontally oval and tilted, and the general fundus showed the inferior chorioretinal coloboma ranging from 5 o'clock to 7 o'clock position with barrage laser around the periphery, and rest of the fundus was attached. So she was a case of cataract left eye with type 2 iridofundal coloboma lasered and a mild zonular dialysis. So to summarize all of my cases, my first case was a case of traumatic cataract with a moderate zonular dialysis. So my plan of management would be a phacoemulsification with the placement of CTR with PCIOL. My second case was also a traumatic cataract with a severe zonular dialysis. So my plan of action will be a phacoemulsification with placement of CTR plus CTS oblique a Cioni ring. My third case was a case of Marfan syndrome with a severe zonular dialysis, both eyes. So my plan of action will be lensectomy with glued IOL or a iris floor lens. And my fourth case was a case of iridofungal coloboma with a mild zonular dialysis. So I'll move forward with the phacoemulsification with CTR and pupilloplasty. Thank you.
Thank you, Dr. Rimil, for taking us through the entire spectrum of different types of subluxated lenses. And before we take up for discussion, we'll have Dr. Vijay, who will present us a master class on how he managed this spectrum of cases. So it's in continuation. After that, we'll have a panel discussion. Dr. Vijay, sir.
So is my screen visible?
Yes, Vijay.
Sir. So I'll be discussing about the management of
Yes,
this
sir. Yes, sir.
Yeah. So I'll be discussing about various scenarios which Dr. Rimil has just presented. So as we know, now based on this, there are various etiologies of lens subluxation. Trauma is one of the commonest etiology which lead to zonular dehiscence and subsequently subluxation of lenses, followed by iatrogenic subluxation. So many a times a neurosurgeon who is doing a hard cataract, he exerting too much of pressure on the zonules can lead to intraoperative subluxation of the lens, and that can then has to be managed intraoperatively. Then cases like iridofundal coloboma, usually there is iris is absent in inferiorly, also associated with the fundal coloboma, and also the zonules are absent in such cases. Now these three cases usually post-trauma, iatrogenic and iridofundal coloboma, the rest of the zonules are good. So this is a non-progressive type of zonular dehiscence and lens subluxation. But then comes the other spectrum of cases. If you see the ectopia lentis cases, as have been discussed in Marfan syndrome or homocystinuria and all other causes, that is a progressive type of subluxation. Similarly, if you see the pseudoexfoliation syndrome, again the zonules keep on becoming weaker over a period of time, and again this is a progressive type of subluxation. And similarly for hypermature cataract. So your approach in cases of non-progressive versus progressive type of subluxation has to be different, and the progression has to be accounted for before you plan whatever type of management is planned for that patient. Now, a thorough clinical evaluation, as has been highlighted by Mishra sir in the starting, that you have to do a thorough pre-op workup. Symptoms, usually these patients with lens subluxation, they present with progressive diminution of vision. This progressive diminution of vision is either due to the associated cataract in these patients as in blunt trauma, or it may be due to the change in the refractive error. Now, change in the refractive error could be because of subluxation that causes rounding of the equator, and if this subluxated lens is bisecting the pupil, that can induce a lot of also there is a lens tilt, so it can induce any type of refractive error based on how much is the subluxation. Also patients can have a lot of halos and glare because of the equatorial edge once it bisects the pupil. The patient also has a monocular diplopia in such cases. Signs, very important to see preoperatively, include iridodonesis, phacodonesis, rounding contour of the lens edge. Now, wherever the zonules are broken, the lens edge become rounded, because otherwise the zonules keep on pulling it equatorially. But if there is a loss of zonules in that area, you can see the rounded equatorial edge. Sometimes in Marfan syndrome, you can see the stretched zonules. Also, you should evaluate if there is a vitreous in anterior chamber and what other comorbidities are there in addition to subluxation and the cataract. That has to be thoroughly checked and evaluated. the extent of zonular dehiscence has to be determined preoperatively so that you can plan what type of surgery you have to plan in such patients. Now, based on the extent, it can be labeled as a mild if it is less than 3 clock hours, moderate if it is 4 to 7 clock hours, severe if it is 7 to 9 clock hours, or advanced if it is more than 9 clock hours. Then a thorough evaluation has to be done, especially in cases of Marfan syndrome. A systemic evaluation and a consultation with a physician is very, very important. UBM or ASOCT may not be much useful to see the zonular dehiscence, but UBM, especially in cases where there is a corneal opacity or there is a non-dilating pupil, in those cases, to see the extent of zonular dehiscence, UBM can be very, very helpful. The biometry has to be done correctly, and specular microscopy in case there are other comorbidities, lot of vitreous in AC. In those cases, the specular count should be done so that you can counsel the patient properly before undertaking the patient for surgery. Now, indications for surgery: decreased vision. If there are chances of amblyopia in a pediatric patients, urgent surgery may be required if lens is dislocated anteriorly or posteriorly, if it is associated with corneal decompensation or causing a secondary pupillary block or a angle closure glaucoma with raised IOP. So these patients should be planned for surgery. Now, while planning the surgery, what are the various factors again that you should consider in your operation theater? So extent of subluxation is that I have discussed clinically, progressive or static status of the zonular dehiscence progression, whether you are planning a back fixation or a lensectomy, then availability of various types of capsular support devices with you, be it iris hooks or a capsular capsular hooks, very important, and back fixation devices should be available with you preoperatively. You should definitely check them that they are available so that you don't face any problems intraoperatively. How much is the expertise of surgeon, age of the patient, status or otherwise, these are other factors. And one very important part is explaining the prognosis to the patient, because usually other comorbidities, maybe, for example, in a blunt trauma, patient may have a choroidal rupture, or iridofungal coloboma may have a extensive involvement of the retina, including the fovea. So in those cases, the patient should be given a realistic expectations of their visual outcome after the surgery. Now, various back stabilization devices, I'll just tell in short. So you may have a capsular tension ring, or you may have a Sioni ring, single or double eyelet, or you can have a capsular tension segments, which Dr. Jayanand will cover in his talk. Now, how should you determine that which size of capsular tension ring you should choose? Now, there are two factors determining that. One is the axial length, and other is the wide to wide diameter. So in normal adults, say around 24, 25 axial length, you can choose a 11, 13, that is type 14C of Morcher type CTR. But in very short eyes, you may have to go for a smaller, maybe 10, 12 CTR. And for very long eyes, more than 28 millimeter, 12, 14 size CTR would be a better option. Then if you have to stabilize the capsular rim and the zonules, it's better to choose the capsular hooks compared to iris hooks, because iris hooks are usually rigid. They provide support at the capsular axis margin, but the capsular hooks, they provide support till the equator. So there are better options available for giving the support in cases of subluxated lenses. Now, CTR. When should you implant the CTR during the surgery? So the dictum which goes for CTR is as late as you can, but as early as you must. So if there is too much of stress on the zonules during the procedure, you may have to insert the CTR early. But if you put a CTR early in the bag, that can actually cause your cortical aspiration to become difficult. Because under the CTR margin, the cortex may get trapped, and it may be slightly difficult to do the cortical aspiration in such cases. So in those cases, instead of Morcher, you can also use a Henderson type of ring, which is shown here in the lower diagram. So that can be used. That cortical aspiration is a bit easy with the Henderson ring compared to a Morcher type of ring. I'll just show some videos about this. So this is one case of ocular trauma. You can see that there was a posterior capsular tear which is healed with scarring. So we started doing there was no phacodonesis or iridodonesis in this patient. So we started with the routine surgery, just thinking that if posterior capsule opens up, then we may go for a different surgery. But let's try a cataract surgery in this patient. So once we started the cataract surgery, everything was good. till that time, when we remove the lens, now you can see here that there is a zonular dehiscence, which is extending from say 2 o'clock to almost 5 o'clock position. So be careful, just note it at a correct time, and you can insert the viscoelastic initially to, and then after that you can place a CTR. Now here axis we have done a usual slightly 5.5 millimeter axis. So CTR, putting a CTR through a small axis again can be challenging. So again, in trauma patients, just keep your axis larger in size. You can use a forceps or you can use two dialers like this, and we could implant the CTR in this patient, and subsequently lens was implanted, and patient had a okay outcome after that. It was only a mild dehiscence, so we could get away easily by putting a CTR and placing the IOL. Now this was another case where you can see that the subluxation is significant from 5 o'clock to up to 10 o'clock position, 11 o'clock position. So almost 6 clock hours, 7 clock hours of subluxation. So rhexis in such cases, cystotome is not a good option. It's better to use a forceps, because in forceps the pull is, you can pull it's a dual pull, not only the circumferential pull. So you can do the capsular rhexis easier with a forceps compared to a cystotome. And the capsular hooks would have been a better option in this case, though we are using iris hooks in this, but capsular hooks are definitely a better option than iris hooks. And once we stabilize the bag, then we completed the phacoemulsification. And after the phacoemulsification was completed, it's very important, this part now, that before you remove the phacoprobe, you insert the viscoelastic from the side port so that your bag does not collapse. Because if it collapses, again, it can increase the subluxation. And that part is very, very important. And once you have completed this, then this Harrison pouch is made, and a Sioni is threaded with a railroad, the 10-0 needle is railroad, and once the Sioni is placed in the bag and a suture is tied, and once the suture is tied, your Sioni is in a good position. Now it has taken care of that subluxation. Now bag is already centralized, and then you can place the intraocular lens. Another important part is the haptics of the intraocular lens. Also you can put in the same axis where there is a maximum zonular dehiscence, because that will also supplement your CTR or a Sioni or any other bag stabilization device. That part is also very important. Now, this is another case which was presented by Dr. Rimil. Now, here you can see, following a blunt trauma, there is a rosette type of cataract and also subluxation. So you can put a viscoelastic nicely, and also the especially the viscoat, if available, that you can put in the area of zonular dehiscence, because that will prevent any fluid from going into the vitreous and causing the hydration of the vitreous, and also any prolapse of vitreous. So here, after removing the nucleus, so before cortical aspiration, because the subluxation was increasing, so we implanted the CTR before we removed the cortex, and it went off easily, and we did not face much difficulty in cortical aspiration. But if you put CTR before cortical aspiration, it does cause some difficulty in removal of the cortex, as we had discussed earlier. Okay, so now this surgery is, again, before removing the irrigation aspiration, you have to fill up the bag with the visco so that it does not collapse, and then the IOL is implanted. Now this is the case which was a case of a keyhole pupil. There was a cataract in that entire keyhole area. So patient had a very poor vision of counting finger, and also there was a small subluxation inferiorly. So especially in iridofundal colobomas, usually cataract, what you see on the slit lamp, it's much harder than that. Once you operate these patients, it may be slightly more difficult. Although in this case, the subluxation was only 2 clock hours. So here we just implanted the intraocular lens, and we placed the haptic in the axis of that 2 clock hour of subluxation. And after we completed the IOL placement, then we also did a single pass 4th row, so that patient does not get any halos or glare through that iris defect in this case. So after passing the suture, these 4 throws are done, and SFT is completed, and that defect is also now nicely covered. Also, this patient was lasered before taking up for cataract surgery. So fundal colobomas, iridofundal colobomas, the retina should also, you have to get the assessment, complete assessment of fundus, and if required, a laser has to be done before you take up the patient. Now, subluxated cases, in cases of ectopia lentis or a progressive subluxation like in a Marfan syndrome, I think this was nicely covered by Dr. Siri in her first video. So we also prefer intralenticular aspiration in such cases. This is the same, you can make the flaps. Once you make the flaps, I'll just go ahead. So you can have, there are a lot of variations of this technique of glue dial, about the flaps, about use of needle for tucking in the haptics. So again, same here, again, stab incisions are given in the subluxated lens. Usually lens is, its cortical aspiration is quite easier in a younger patient, and you can just do by irrigation aspiration, you can remove that completely, and then a limited anterior vitrectomy, and also you can use a cutter to remove the capsular bag completely. Once it is done, then you can place the glue dial. I'll skip this because this was covered in by the first talk, and the tucking of the haptics are very, very important. You can either use a AC maintainer or a pars plana port depending upon your comfort level. Now, this is another one of my colleagues' video. This I have taken to show the variations in the SFIL technique. Now, in this case, this is a standard Yamane, but here the flange is created by use of 532 nanometer laser. Now, it has to be placed parallel to the haptic, and then settings you can titrate. Either it can be a continuous or a repeated, maybe around 20 milliwatt for 1.5 second in case of repeated. And once you get a good flange, that gets, you can just place it subconjunctively, same as Yamane's technique. Very important, again, another aspect is your parameter should be lower. Good hydrodissection, nuclear rotation should be achieved. If you can prolapse soft cataract, you can prolapse, and you can do in the iris plane the phacoemulsification. And cortical aspiration, again, circumferential stripping is better than perpendicular pull, because otherwise that is likely to increase the subluxation. So if the subluxation is, say, less than 3 clock hours, you can go ahead with a CTR. If it is 3 to 6 or maybe up to 8, you can go with a single or a double eyelid CONE, or you can put a CTR. Along with that, you can put the capsular segments in the zone of dialysis. And ectopia lentis or a progressive zonular weakening, lensectomy or intralenticular aspiration with glue dial preferably. Otherwise, retrofixated iris claw lens is a good option. Thank you for your attention.
Thank you, sir, for taking us through this exhaustive masterclass on all the techniques of managing the subluxation. So we can have a screen of the share screen. Yeah. Sanjay, sir, what is your threshold for non-device options for subluxation in which you can manage just with altered phacoemulsification parameters and maybe orientation of the haptics alone, and you do not implant a CTR and you think you can get away with that? And does the position of the subluxation also have a role in your decision making?
Of course, Manpreet, that's definitely a very important aspect of it. If the subluxation is less than 2 clock hours, and if your subluxation is in a non-dependent, suppose if it's area, then you can leave it without putting a CTR. But if your subluxation is more than 2 clock hours, you have to put a CTR. It's very important to see while doing surgery that you have to be very gentle, because during the surgery, especially when doing a cortical aspiration or doing a phaco or a rhexis, you tend to increase if you are not very careful, you tend to increase the dehiscence, and then you land up in trouble. So you have to be very careful in that. And beyond that, yes, definitely CTR. And if it's more than 4 to 5 clock hours, then you have to put a segment or a Sion's ring to stabilize the bag. And if it is much beyond that, then you have to go for a lensectomy and do a SFIL.
Dr. Rama, as sir said, Dr. Vijay said that CTR should be as late as you can, but as early as you need. Even we have a tendency to delay implanting the CTR because it does make the cortical aspiration challenging. But there are some surgeons who routinely prefer whenever they see a subluxation at the beginning. So can you give us an insight into the pros and cons of both approaches, doing it early vis-a-vis late?
See, with the CTR being placed early, it gives you a comfort. Like if you can go ahead with your routine parameters and the comfortable parameters what you are used to, and finish up the surgery. That is one advantage of going for an early CTR. But at the same time, as was rightly pointed out by Dr. Vijay, it's like completing your aspiration. So the retained lens matter chances are more when you're doing with that, and even some of the times with the lens matter being there, the purpose of the CTR is being going into the equator and then stretching it and positioning it towards the ciliary body over there, so where the journals are deficient. So with the material lens material still being there, the position also can get disturbed over there. So these are the disadvantages. So better, as suggested by Dr. Vijay, and it's that you delay and just definitely whenever it is needed, rather than going for a conversion of removing the entire capsule. Better to perceive that particular moment when you are supposed to put the CTR, and then decide and do it at the right time. And I think I have one point. If I just want to know with from the other faculty, what is your opinion of opting for a three-piece IOL in a lesser, like less than 3 clock hour subluxations, rather than going for a CTR? And if the patient is opting for a monofocal, so what is your opinion regarding going for a three-piece IOL, because that can do the work of a CTR over there at the place where there is a jonular dialysis, if you can dial the haptic into that region. So I just want to know from others what they think about it.
Yes, sir, definitely three-piece IOLs. That is what I was asking Sanjay sir also. Would you prefer changing the lens? We do put three-piece IOLs with the haptics oriented at the across the subluxation to provide additional support to the bag. That is a very good option, especially if you do not have a capsular tension ring and you just have a subluxation on table. You may be sometimes, especially in the hard cataracts or in advanced hypermature, when you're doing irrigation aspiration, in the end you end up with a subluxation or a bag dialysis. At that, even in those scenarios, a three-piece IOL is an invaluable addition, especially if you do not have a CTR in hand. Not everyone will have a CTR backup at all times, so it's a useful option.
And also, I think I don't know whether someone is opting for it, but is there anybody who is opting for a toric IOLs in these kind of scenarios? I don't think it should be. I think
I
when
think
one
we
should
have a panel of
pass on this
safe
message.
surgeons rather than sorry surgeons today. So we will not have multifocals and torics in subluxation discussion. I think that's for a more flamboyant panel
Actually,
than ours.
there are people. I have seen quite a couple of people who are discussing that with patients and giving these options also. That's why I just wanted to pass on this message through this webinar. So, like, I just that's why I asked this question. So, if we can give the message through this webinar regarding that.
Yes, a very good message, sir. Dr. Vijay, sir, what would be your phaco-emulsification parameters be for the audience who are just venturing into phaco, the initial stage? What would you suggest changing in your phaco parameters when you encounter a case of subluxation?
Phaco parameters for IOP, we go around 50, maybe slightly below below than 50. Normally we go for around 65. Flow rate is also reduced to maybe 20 to 30 if there is a significant subluxation. Vacuum also we decrease to around 250 to 350. So that is how normally around, say, if it is 4 to 7, 8 clock as a subluxation, in those we go with these parameters. And torsional is definitely better than longitudinal. We go for a direct chop and you prolapse the nucleus and may do a phaco slightly anteriorly if you are finding that bag is that dehiscence is increasing. So so that is, these are the parameters normally we use. So,
and in your case, I just wanted to point out you showed iris hooks to stabilize the bag, and you said capsular
Yes.
hooks would be better. Even I
See,
prefer
that
doing iris hooks. So, what is your preference in the real world scenario? We all know theoretically capsular hooks are better. So, can you weigh the two? Which would be
see,
better
uh,
in terms of?
capsular hooks are definitely better because if you see the structure, it goes till the equator of the capsule and it is knobbed at the end. Iris hooks are definitely rigid, but they are much easier to and usually easily available. So in most of cases, we go for with iris hooks, but capsular hooks are definitely a better option because of the material. They are soft. They give the support till the equator. So capsular hooks would be a better option than iris hooks in any cases
Just
when
a
there
bit
is
more
iris.
fiddly to implant. That is why, and more less easily available. So that is why a
Yeah,
lot of us tend to make do with iris
go
hooks
with
because
iris
you
hooks. Yes,
have them on hand more easily. Yeah,
yeah,
that is
absolutely.
true. Another thing I wanted to highlight in the phaco parameters, etc., is that what we have to prevent in subluxation is the anterior chamber fluctuations. So whenever you're coming out, taking out the handpiece, putting an IOL, the anterior chamber should not fluctuate. So your paracentesis should be used to inject a cohesive OVD to maintain the chamber at all times whenever you are changing your instruments. So that
Absolutely.
also will help prevent enlargement. So over to you now, Jayanam, to discuss the capsular tension
Yes,
segments.
I'm sorry, ma'am. I will try to share. And in last
Yes,
time,
otherwise now I have your PPT ready. I'll share for you. Just in case you
I think
cannot, just try once. Yeah. Yes.
so. I'll. Good evening, everyone. So I will be sharing a case of a very simple case. I would say because the discussion has been so exhaustive and Dr. Vijay has covered most of the things. So I had this case, 50-year-old female patient who had a diminution of vision in the left eye following the blunt trauma with a ketchup bottle cap. And on ocular examination, right eye was within normal limit. In the left eye, the vision was 6/60, which was improving to 6/24. And anterior segment picture, we can see there is a traumatic mydriasis along with the anterior as well as posterior subscapsular cataract. And the significant posterior subscapsular cataract was visible on the retroillumination along with the pupillary sphincter tear. A significant phacogenesis can be appreciated with the eyeball movement. Extent of zonal dialysis on the left lateral gaze, it was extending from the 2 o'clock to nearly 8 o'clock. Obviously, it was more than that on the table. And gonoscopy show no evidence of any angle recession or cyclodialysis cape, though there was a few synecdoche. So our plan was to do a phacoemulsification along with the posterior chamber IOL along with the CTR plus CTS. So here is the surgery. So after doing a limited peritomy, I am cauterizing the bleeders. The marking was made around 2 mm. Now I'm creating a scleral groove for the facets of the needle and the suture. The main incision was created little away from the area of zonal dialysis to avoid any fluctuation in the vitreous. Now I'm staining the anterior capsule. At this stage, the precaution should be taken that the dye should not go in a vitreous cavity. Otherwise, one will have difficulty with the visualization as well as the blue vitreous. So after forming the anterior chamber, I am coating that zonal dialysis area with a viscoat so as to that act as a barrier for the fluid going from the anterior chamber to the posterior segment. And to start with the capsular axis, I will be starting from the area of intact zonal so that it will provide some counter traction. And I will be doing it in a very careful manner because this is the most important step in any back fixation. I'm trying to do in a two-stage kind of rexis and as well as maintaining the shaft between the capsule rexis and the fornix so as to get a support to the CTS. The hydrodissection was carried out from the same area. followed by hydrodelination. And here I'm trying to rotate the nucleus. Uh, I think this step should have been avoided because that can increase the area of zonal dialysis. Now I'm creating the side port to engage the capsular hook. One capsular hook I am using. I think two capsular hook was needed because the dialysis area was more. And here I'm doing a trench and manual separation of the nucleus. And as Dr. Vijay said, with a very slow parameters, I'm doing removing the center part of the nucleus. So after doing that, the epinucleus part was I was removing it, but what I noticed that the fornix of the bag was not stable, so it was trying to come into the phaco probe. So at this stage, I decided to put the CTR to support the fornix of the bag. And after injecting the viscoelastic within the bag, I am putting the CTR with the bimanual technique from the side port. So one of my instruments, Sinsky or either chopper support the CTR, and second instrument guides within the capsular bag. So it ensures that it goes into the bag and not into the sulcus. So after that, I am carefully removing the rest of the epinucleus. And the care has to be taken that because you have to keep forming the bag so that the poster capsule shouldn't be coming into your phaco probe or IO probe. And with slow parameters, the completion of epicortical plate was possible. And again, as mentioned by Dr. Vijay, every time you have to form the chamber whenever you come outside the antechamber, so that you avoid the antechamber fluctuation. The most tricky part after the CTR implantation is the removing of the cortex. And here, what I am doing that instead of radial extension, I am pulling it in a tangential manner to dislodge the cortex which is trapped behind the CTR. So after clearing the cortical fibers, now it's time for the implantation of the intraocular lens. So the difficulty with the intraocular lens implantation in the bag, because you have to keep forming the bag all the time because bag remains on flatter side compared to normal eyes. So we can use a single foldable IOL or three-piece can be used, but with CTR and single piece IOL is okay in my view. So after removing the capsular hook, now it's time for the placement of the CTS. So what I'm doing, I'm creating the space between the iris and the capsule so as to that needle or any instrument doesn't damage your the capsules. And right now I am using this is Gore-Tex suture, which is CV8 suture, and passing through the anterior eyelid fixation of the CTS. I have straightened the needle. Needle comes in a slightly curved manner, and with a 26 gauge needle, the other instrument is helping to push back the capsule so that my needle doesn't hit that capsule. And with the docking technique, I was able to exteriorize the one end of the Gore-Tex suture. The Gore-Tex sutures comes with a very long end. I mean, it is around 76 centimeters. So I have cut into very small part. And other end of the, now I am dialing the CTS inside the bag. You have to make sure that eyelet fixation comes above the anterior capsule and the rest of the part going inside the fornix of the bag. And I'm creating the sclerotomy for the because I am using the MST forces to retrieve the other end of the suture. So after exteriorizing the both the ends, I am just positioning the CTS in the intended axis. So now I'm placing the sleep knot that basically helps in a titration at the end of the surgery. So after doing that, the viscoelastic was removed from the anterior chamber. Sorry. So after removing the viscoelastic, I'm hydrating the all the wounds. And once I'm sure about the anterior chamber, I'm doing final knot. And after the cutting it, I'm internally rotating that thick knot inside the eye, and rest of the suture will be lying in the scleral groove. So after the final knot, I'm doing a final centration of the IOL. And conjunctival closure was done with the help of a glue. So that's the end of the surgery. In a post of day 1, the vision was around 612 with a mild corneal haze. This is post of day 7. We can see very well center IOL on ASOCT as well. And this is a magnified view with retroillumination. We can see the fixation eyelid well above the anterior capsule. And the suture is also well covered with the sclera. And this is a 10-month follow-up of the, I mean, the suture is well buried, and there is no suture extrusion or the conjunctival erosion. So special consideration already been discussed. So thank you.
Thank you, Jayanand. It is a pleasure to see your surgery after so many years. So Jayanand is an excellent surgeon, I would like to say, and beautiful technique demonstrated. But you have brought up a very interesting discussion point: Gore-Tex versus Proline. Tell me now, which suture you prefer and why?
Currently I have completely shifted to Gore-Tex suture, and
Yeah.
I love the handling and all compared to the Proline, the strength, the durability, as well as the titration is very simple, I feel.
Okay. Okay. Rama sir, what would be your views and your experience? Because Jayanand has shifted sides. We trained him on Proline and he is now Gore-Tex. So I would like to know your experience.
Actually, the advantage of see, all of us, we started with Proline only, and nowadays lot many surgeries are being done on Gore-Tex, especially for all these scleral fixated sutured scleral fixated IOLs. And this one also, CTR fixation also, it's with Gore-Tex. The advantage of it being over time, it gets integrated. There is kind of a fibrosis which is happening, and that becomes a permanent fixation, not like Proline where it doesn't change, and there are chances of exposure and other things afterwards. So that chances are very minimal with, I can say, nil with Gore-Tex. So that is the advantage of Gore-Tex. So that's why more and more preference is being given for that now. And I think over time, most of us will be shifting to Gore-Tex only because of that better stability over long period.
Okay. Dr. Vijay, what is your perspective on this?
Definitely. I think Gore-Tex would be a better option over a period of time, because you do get so many cases where knots are exposed. Patient is symptomatic after 6 months, 1 year, with a lot of foreign body sensation in that area. So Gore-Tex would be a better option, though I have not shifted, but Dr. Jayanand has motivated me to shift now next to Gore-Tex.
Yes, but what Jayanand does is not that easy. I would like to say he's a very fine surgeon.
I think it was the most simplest case what I showed compared to Dr. Vijay and
Jayanand being humble. But I'll just point out 2-3 important points that Dr. Jayanand's surgery had. One, the centering of the rexis. It should not be what you are seeing, because the lens is subluxated. After fixing, it has to go downward. though he has done a perfect centering of the capsular rhexis, that after fixation it goes to the center, the capsular rhexis margin. Otherwise, if you see, you must leave a gap of 2 to 3 millimeter from the equatorial edge. So that point is very, very important. Then slip knot, Gore-Tex. So these things are very good in his surgery. Also, in addition, you can also use an iris hook, especially if you're not putting a slip knot. So iris hook in the reverse position, you can just hold and engage the CTS in that during the surgery. And once you complete it, you remove the iris hook and then tie the knot. So that will keep your knot also tightly. It will keep the that CTS tightly in place. So that is also other option. But you showed very good steps and nice surgery.
If
So,
there is no sufficient shaft between the fornix and the anticapsule, what
Yeah.
happens when you give a tension on the suture? It causes a tilt in the CTS segment, so it will
Absolutely.
not lie horizontal. So that
Yes.
problem is there. I mean, if it is smaller side.
Yes. So we always, that is why CTS is done along with the CTR to help give
Yeah.
equatorial tension with the capsular tension ring, and then take care of the area of the dialysis with the capsular tension segment to center the bag. So coming back to the Gore-Tex and Prolene debate, so when it started, it was mainly being compared with Teloprolene, which had a significantly higher risk of breakage. Then they shifted to Ninoprolene and said that the breakage risk is lower. So even the evidence is divided, because there are surgeons who propagate Ninoprolene, and they say that if you have breakage and slippage in the long term, then it's more to do with maybe overtying on the table and your technique itself rather than a fragile nature of the 90-prolene. 10-0 definitely fares inferior as compared to Gore-Tex. Now, Gore-Tex has a very good long-term stability. The only issue is it's a bulkier suture, so the risk of eroding through the conjunctiva in long term is more. So this eventually will come down to surgeon expertise and preference, because in experienced hands, I firmly believe that both will work well. And it's so you cannot really write off 90-prolene and then navigating it intraocularly, especially when you're doing various types of fixations, going through the back fixations and fixation of the subluxated IL bag complexes, iridodialysis repair. It will still have a role to play, but Gore-Tex is a viable alternative, and 90-prolene cannot be totally written off, but 10-prolene should be avoided. That is what all the literature says as of now. The second is Hoffman pocket versus a flap. What would you prefer when you are putting a CTS or Sioni? I would like the opinion of the house.
So I prefer Hoffman pocket because it's easier to bury the suture, and plus you're not causing any weakness there. Although you can make a flag, put a glue and close it, but Hoffman pocket I prefer over the flap.
Okay. Jayanand, any inputs?
Ma'am, the knot form in a Gore-Tex is slightly bulkier, so it needs to be well secured under the sclera. If you leave it in a groove, then definitely it will cause erosion. So either flap or either the Hoffman pocket or anything which can bury your knot, or you can internalize knot as well.
Yes.
So I think
So I
any
think
suture should not be left under conjunctiva.
yes.
My
And
point.
one more thing is, for when you're beginning the surgery, already you are worried about a lot of things. So a flap makes it easier when you're just starting out with these fixations, because you need the space. When you exteriorize the needle and the suture, you need at least 1.5 to 2 mm. Otherwise, they may cut through when you're tying as well. So visualization beneath a flap helps when you're starting out. With experience, as in Vijay sir's stage, he does not really need to see where he's passing. He knows exactly the distance. So a Hoffman pocket is easier, does not require that much manipulation, easier to close and meter. So Siri, coming to experience, so you are beginning with the fixations in your career. What are the challenges you face when you're doing Sioni? You have to unmute yourself.
Okay. So the first of all, the phaco itself, because we initially operate the normal cases. In such cases, as Sir said, the centration of rhexis is very important. We cannot center it at the subluxated level. You have to center it around the visual axis. So I generally use capsulotomy for other cases. In this case, I tend to use forceps because I have more grip, and this thing counter traction is not there from the zonular level. It will become more easier. Secondly, the most difficult step that I've encountered in very few cases that I've done is externalizing the 90 proline sutures, because they have to go between the iris and the bag. We cannot perforate the bag at all, and then the space is also not adequate. One thing that I have been taught my mentors is that from the opposite paracentesis, you inject a bit of OVD to create the space so that you do not damage the above and below structures. And then again, the orientation of the ring itself has to be done properly. I mean, we cannot entangle the sutures after it is put inside. And again, of course, phaco has to be done very meticulously so that we save the bag to put the CONE itself. So all the parameters are lowered from irrigation, aspiration, everything is lowered and done in a very controlled manner.
So, Dr. Sridevi, for her, what would be better when you're beginning, a capsular tension segment or a CONE, if you have choice of both?
I think for a beginner, actually, a segment may be a little less challenging because one is that when you're combining with a CTR, it gives you the option of putting it at an earlier stage if you feel the need for doing so. It gives you a zonular stage, maybe at the stage of phaco or cortical aspiration. And second, it is much easier to handle a segment, in terms of insertion and centration as opposed to a CNE. And third, maybe for a more experienced surgeon, if you have a more extensive zonular dialysis and you need multiple areas of fixation, then there again, a segment is a better option. You can use multiple segments. Whereas CNE, you have one eyelet and then you'll have to get a double eyelet one, which is much more complex. So I would,
So,
I have a
Dr.
doubt,
Brigade, do we have
ma'am.
you here? Yeah, please.
As a beginner surgeons, when we're operating on the subluxation lens, we use iris hooks or capsular hooks. Sometimes we do not know how tight or loose it is. And when we are doing phaco, sometimes these hooks can actually rupture the bag and, cause PC dehiscence. Suppose if you put a CTR before completing the phaco, and it will be a very difficult and challenging thing because we cannot leave the CTR in a rent. So do you suggest for a beginner surgeon to put the CTR before the surgery, or should we actually wait patiently till we complete and manage with the iris hooks
So
rather
there
than...
is a saying which says, you should delay it as much as you can, but you should put it as soon as you need it. So you
Okay.
don't put it unless you really need it. So if you're able to
Siri,
manage
you
your
were not
phaco,
listening to Dr. Vijay properly.
yeah, so when you have your hooks in place
Okay.
and if you're able to manage your phaco with your hooks stabilizing your bag enough, then you don't need a CTR at that stage.
Okay.
So then
I
you
think
manage with your hooks,
I
So
think not putting a CTR will increase the risk of PCR manifold. I mean, if it is,
Okay.
that is also
yeah,
there.
yeah,
Because
because
when you
poor
don't
zonular
stabilize the
support.
equator, even if you stabilize
Yes.
your anterior capsule, as in Jayanand's case he was showing during the video, the back tends to come from the equator. So it's a very fine line. That is why
Yes.
subluxated is for experienced surgeons who can handle all these. Matlab, for those who are watching this webinar, it's seeming very seamless that, okay, you can put a CTS in this case, this illa in this case. We don't actually breathe when we are passing a CONE suture because you can have the entire surgery coming apart in the end. It's not as easy as it looks, and it requires expertise beyond what is required in a normal phacoemulsification. So that is the take-home message, that do not take on cases that you cannot tackle at your experience level. These surgeries are much more complicated than your routine phaco cases. And everything has its pros and cons. Like Jayanand also did without passing a CTR initially. And when he saw the back coming, he took a decision to inject a CTR. So these decisions happen in real time. You have algorithms, but no algorithm is going to teach you what to do in each case. Each case is going to behave differently. So that is what you have to be aware of.
And keep your mentor around, especially when you are starting, because he
Yes.
can be a big help at this point of time. And another, just one more point of putting a CTR before phacoemulsification is in, especially the harder cataract, when you are implanting the CTR, it may be very difficult to get a plane for that CTR. It can further cause a lot of zonular dehiscence. So that is also the point, goes against putting it just before phacoemulsification. In softer, you may be able to, but in harder, putting a CTR and create a cleavage plane, that again can be very, very risky maneuver.
Being primarily a VR surgeon, I would like to caution all those who are watching the webinar. Like yeah, keep a mentor around definitely, but at the same time have VR backup, because these are all, especially if you are a beginner, these are all pretty complicated. So there is every chance that you may require a VR surgeon's backup anytime. So one should be aware about this possibility. So rather than taking in standalone practices, it's better to have a backup and clearly explain to the patient, if at all you're taking in a standalone practice, the possible need for going for a VR surgeon's intervention afterwards. And I just wanted to ask one thing, like nowadays, many seniors who have experience of doing FECOS for more than 30 years, they are presenting their long-term follow-up patients developing in a normal FECOS done, and those IOLs getting dislocated or subluxated over time, say after 15-20 years. I remember Dr. Vasavada's presentation and also Tityalsa's presentation. So in like Dr. Vijay has mentioned, there are two types of this subluxations, one progressive and the other one non-progressive. So those non-progressive cases, and where we are fixing with CTR or the CTS, so how does it stay for longer time in this scenario? Because already there is this jonular adhesions or a weakening of the zonules at one point, and we are fixing only at one point. So how does it maintain over long term in the context of those cases, normal cases developing these subluxations over long term?
Sir, in my follow-up of around, say, 15 years, when I started doing these cases, so most of patients, they do not, especially if you choose your patients well preoperatively, there is no progression of subluxation. But in trauma cases, there may be a zonular weakening, there may not be a zonular dehiscence when you are planning a surgery, and if it is at multiple locations, that can actually, over a period of time, make the capsular bag unstable, and it can actually dislocate. So those cases, post-traumatic cases, when you have got a multiple areas of zonular dehiscence, may not be a continuous in one area, then other area. So if those cases are there, in those cases, the bag may not be very stable, and you may get end up in a long term getting a dislocated bag and the CTR complexes in these cases.
Another is, sir, the pseudo exfoliation cases in which there is a progressive pathology going on, the deposition of fibrillar material. Often we have put prophylactic capsular tension rings, and we have seen cases with the CTR IOL bag complex lying on the retina when the patient comes after years. So that is there. And can we prevent it, like in the cases of post-traumatic fixations in which there is no progressive loss, or in which you are doing a back fixation? They are the ones that are unlikely to have everything on the retina. The ones in which you do not expect are more so to end up with late dislocations of the IOL bag complex. And I think Dr. Sridevi can shed light on the dead bag syndrome. That's
Yes.
that I think one of the aspects you were talking about, which is so much in vogue
Yes.
right now.
Yes, I was just going to mention that, that one
Yeah.
more differential that
She's
we
very
should see,
fond of it.
because
So yes.
because a lot of times, because now we see our senior faculty and our mentors cases following up with us after 15 years and 20 years, and they had completely uneventful surgeries. And but now they've come with either a spontaneous PC defect or a bag IOL complex subluxation, and there is no other risk factor, no CTR put, no subluxation noted at the time of surgery. So when such is the history, and when you see the anterior capsular rim, which is very well fibrosed, then you should take into consideration a differential of dead bag syndrome. It's not very common, but then it's not that rare either. And I guess we'll all start seeing more of those cases now. So that is one
And
thing that we
I
should.
think they are more of a complication of perfect surgeries, the one which have been
Yes, so
perfectly polished in the
very
bag.
true.
Yeah.
The excessive polishing, yes. So I
Yeah.
mean now, so I am also a little vary. So tend to leave at least 180-degree of the anterior capsular cells. I don't polish one half, because that is one of the theories which has been proposed can lead increase the risk for dead bag syndrome. So a full 360-degree polishing can lead to that. So that's
And also, Sridevi, many of these cases can have multiple etiologies. Say
yes,
initial subluxation, initial CTRRS1 is done for a blunt trauma subluxation. So this patient
yes,
after 15 or 20 years can develop a pseudo exfoliation also. And the
true,
rest of the
true,
zonules can also become weaker. So there may be a
true.
multiple overlapping
Yes,
etiologies
yes,
which can
definitely.
also
So
result.
uveitis or anything, I mean, any other secondary insults can lead to. That's
Yes.
completely true. Yes, sir, true.
So, Dr. Rimil, anything you would like to know from the expert panel? Any challenges you face? Because I was asking Siri also, because we are presenting right now from an expert perspective, but these cases are not that simple to manage and operate. So if we have your challenges, we'll also be able to better serve the audience that is watching in what exactly are the challenges in these cases. You will have to unmute. Yeah.
Ma'am, for now, the webinar which has been conducted, it has actually covered the wide spectrum of what I knew, and it has covered much more what I had expected from this. So I have got a very much 360 view of what can be the futuristic prognosis of everything, ma'am. So it has served a really 360 degree ground of knowledge for me through this webinar. So presently, I don't have any questions, ma'am. Everything, every doubt, and everything has been sorted really well, ma'am.
Okay, so I think we will now cover the relatively niche aspect of use of femtosecond lasers in subluxation. So I'll quickly take you through it because not everyone has access. It is just an option that we should know. And I think then we'll return to our panel discussion because it's more illuminating than the presentations. So I'll just share my screen. Okay, so I'll just take you to the role of femtosecond laser technology in subluxated lens. No financial disclosure. So just to highlight the intraoperative surgical challenges in a subluxated lens, first is the right corneal incisions. Once you make the incision, the anterior chamber decompresses. You can have vitreous coming into the anterior chamber and through the incisions as well. Then the rexis is challenging because you have to decenter it opposite to the direction of the subluxation so that you eventually end up with a well-centered IL bag complex. And the nucleus emulsification is going to add additional zonular stress. All these maneuvers can cause further zonular stress and breakage. Vitreous management is challenging. It may further extend the zonular dialysis and compromise subsequent phacoemulsification. So as I was saying, during incision, you can have vitreous gel prolapse through the site of dialysis. The lens iris diaphragm suddenly moves upward due to the aqueous egress, and the breakage of zonules and extent of subluxation can increase. During rexis, you can have, in cases with extreme subluxation, further zonular breakage. Vitreous gel prolapse can occur. Then a 26 gauge needle cystotome does not offer you as much control. You require forceps. And even then, there is a risk of rexis running off because of the altered forces acting on the lens complex. During emulsification, the dialysis increases, lens tilt, and broken zonules. So we have gone through the management of subluxated lenses as per the degree of subluxation and the degree of nucleus sclerosis. So in the milder cases, you can get away with maybe a 3-piece IOL and low fluidic phacoemulsification. Then if you have 3 to 5 clock hours, maybe a capsular tension ring, Sioni and segments in 5 to 7, and then 7, 8, or 9 clock hours, depending on the coexisting nucleus sclerosis as well. You may need to go for ICC or a pars plana lensectomy. And these are the factors that we have covered in our earlier presentation beautifully. So what is the role of femtosecond laser technology? If you see, the pulses are going to create capsulotomy, which can be customized as per the location and the size, and nuclear emulsification in toto without creating a anterior chamber fluctuation. So it's a closed chamber nucleotomy and rexis as well as incisions in which the anterior chamber does not fluctuate. So you are not causing any additional zonular stress in these steps which are occurring before your phacoemulsification. And then the intraoperative imaging during laser application gives a unique advantage of customizing your parameters. So this is our study on femtosecond laser-assisted management of subluxated lens with vitreous in anterior chamber. There is also a large series by Chi Soon Fei from the Singapore National Eye Center, in which successful preservation of capsular bag was possible in 90% of cases with severe subluxation, which is higher than if you do a conventional phacoemulsification alone, in which you may need to then do a ILA with scleral fixated or a lensectomy or a ICC. So I'll just highlight two cases in which femtosecond lasers have been used. So this is a 32-year-old male with post-traumatic cataract with 3 clock hour subluxation. So if you see a Lensex platform was used in this case, any platform may be used. You can alter the position of the capsulotomy as per your area of subluxation. So making it centered is much easier. You can see where your lens is, and you get a imaging real time on the right hand side, as you can see, in which you can see the lens tilt as well. So a closed chamber nuclear emulsification capsulotomy creation and incision was done in this case. So once you open the incision, the pre-created femtosecond incision, you just have to remove the capsulotomy, do a hydro procedure, and just emulsify the nucleus. So without hooks and without any capsular tension support hooks or putting a capsular tension ring, you can complete the phacoemulsification. And in this case, after completing the nuclear emulsification, a capsular tension ring was placed and the intraocular lens was placed. So for lesser degree of subluxation, the surgery becomes almost as if you're doing a routine surgery, and there is no extension of the extent of subluxation and no chances of vitreous coming. So a closed chamber procedure done well is what the femtosecond laser offers you. So this is a second case in which there was a higher degree of subluxation, 6 clock hours with vitreous in anterior chamber. So in these cases, if you do directly, you will have to take care of the vitreous in anterior chamber by doing a limited anterior vitrectomy. During the anterior chamber fluctuations during the vitrectomy, you may end up by extending your zonular dialysis and breakage as well. This is prevented by a femtosecond laser application. As you can see, the rexus is quite decentered because you have to center it as per the lens and not as per the pupil or the limbus in this case. And you can see the cavitation bubbles are getting enmeshed with the vitreous over here. A nucleotomy was created successfully. Everything happened in closed chamber. So even though there is vitreous in AC, it's not going to collapse through the incisions, and there is going to be no anterior chamber fluctuation. So that is the advantage of femtosecond laser technology in these complicated cases. So once the femtosecond laser application is complete, of course, you do have to emulsify it as per the normal steps. And iris hooks in this case were used for stabilization. There was a lot of vitreous in anterior chamber, which is now taken care of, but you don't have to worry about creating a circular capsulotomy, centering it. And the size of the capsulotomy can be better controlled because when you're doing manually in these challenging cases, you tend to go smaller. You do not want to run off and you do not want to be too eccentric. That is taken care of. This video is courtesy Professor Tityal. And once the vitreous is removed, the pre-fragmented nucleus can be easily emulsified using your standard phacoemulsification probe. So as you can see, despite being such a large subluxation with so much of vitreous in AC, you can see minimal anterior chamber fluctuations happening. There is no struggle that is visible, which is in part, of course, due to the expertise of the surgeon. But you can see the bag is not coming, and despite being such a large subluxation, there is no extra vitreous coming. It all seems very stable and well controlled, which is what your aim should be when doing a case of subluxated lens. So after the nucleus emulsification was completed, then cortical aspiration. So as you can see, dispersive OVD is being injected simultaneously before removing the phacoprobe. This is very, very important. You do not let your anterior chamber fluctuate at any point of time when you are handling these challenging cases. Not only subluxation, any challenging case, your AC should not fluctuate. So a capsular tension ring was placed. Now, if you can see, the iris hooks are in situ during placement of capsular tension segment ring. This is another very important point because whenever you're passing a ring, if there is more subluxation, it will extend when you're passing the ring. So a iris hook stabilize the bag when you are passing the capsular tension ring or Sioni rings as well. So post-operative day 1, this case could be managed only with the capsular tension ring without need for fixation. So you can see over towards the right hand side, there is the area of subluxation visible, but it is well centered, and this minimal maneuvers getting away with the 6 o'clock hour subluxation is optimal. And we had a well centered ILN bag with no vitreous in anterior chamber. So management is based on the etiology, grade of nuclear sclerosis, and extent of subluxation, which we have seen throughout this webinar. Surgical principle that everyone should take care of is to avoid anterior chamber fluctuations and minimize further zonular loss. How do you do it? Incisions avoid the site of subluxation. Capsular rhexis continuity is imperative for successful surgery. If you have a discontinuous rhexis, extending rhexis, then capsular tension ring is out of the question. You need a continuous anterior capsular rhexis to put these implants as well. Nuclear emulsification, avoid rotation, do a slow motion phacoemulsification with lower parameters, and femtosecond nucleotomy will help you get pre-fragmented pieces. Stabilization of the bag is important with iris or capsular hooks during emulsification, capsular tension rings, peony ring segments for permanent stabilization. Thank you for a patient hearing. So one point I wanted to highlight was, like, not all of us have access to femtosecond, but if we see, everyone says that the outcomes of flax and conventional phacoemulsification are comparable. I think the limited role that femtosecond has is in these challenging cases. It may be subluxation, it may be posterior polar. This is where it really shines and does make a difference in outcomes. In routine cases, yes, in experienced hands, I think femtosecond is as good as conventional phacoemulsification.
So, Manpreet, any studies you have conducted, any comparative studies of flax versus phacoemulsification in normal phacoemulsification in such cases?
Not in subluxated. In subluxated, we have published our outcomes of femtosecond laser, but conventional versus femto, we have a lot of studies in terms of incisions, the descemet membrane detachment rate, which is of course less than femtosecond because you don't need a keratome to enter, and they are morphologically constructed, architecturally stable incisions. Then in terms of nuclear fragmentation, since you have pre-fragmented nuclear pieces, then the cumulative dissipated energy is much less. That is there. In terms of visual outcomes, even though we found a advantage in terms of all the anatomical parameters, when it came to visual acuity, we did not find any difference in routine cases.
Okay, the videos were wonderful. I think they were very good, looking very simpler with the flax than
yes, and even the 6 o'clock hour subluxation, it's partially
Yes.
femtosecond, partially the surgeon expertise, because the sir's hands are literally hands of God while operating.
Yes.
But one thing I would like to say is, whenever we are passing Sioni, like in more than 6 o'clock hour subluxation, one thing, even in my early cases, I noticed when we are passing the ring, the back tends to circumferentially move along the direction of the movement of the ring, and it does lead to increase in the zonular breakage and dialysis a bit. So with time, I have learned that when you stabilize your bag with iris hooks or capsular hooks are more appropriate, and then pass a ring, then you do not end up enlarging the magnitude of subluxation. So it's very, very important when you have cases that are Sioni-able or capsular tension segment-able. CTR you get away with, even without stabilizing the bag. But in the larger zonular dialysis, you do need to stabilize the bag when you're passing the ring. Otherwise, the movement of passing the ring itself enlarges the amount of zonular breakage and dialysis.
I think that's very relevant point and a take-home message when you are passing a Sioni for all of us.
It does make life easier. Once I tried it, I never went back to just passing a Sioni like that, because whenever we are operating, the mindset is ho jayega. Ho to sab jata hai, but it's better to do it the proper way. It does help in the long run. Yes. True.
Ma'am, I have a doubt.
I have a question.
Okay.
Yeah. And now both of you are quiet. Siri.
Yes, ma'am.
Okay,
So please go ahead. I'll ask later.
Yeah. regarding one point which you have mentioned, selecting the incision site, avoid the areas of excision. So,
Yes.
in a case where you have a temporal or supratemporal more than 4 or subluxation, how do you select your incision site?
So if it's temporal, I'll go superior. If it's superior, I'll go temporal. If both of them are equal at superotemporal, I'll go temporal because I like that position. That's the only way. But if I can avoid, I'll
So,
avoid the site of subluxation. So if it's bank temporal, I'll shift to superior. I'll abandon my original temporal preference.
so the number of clock hours, does it get reduced when if it is a temporal subluxation? The choice for your going for the FECO and in the bag surgery.
Sorry, sir, I didn't get the question.
Like when if it is on the nasal side, even if it is 7 or 8 clock hours, yeah, we are still planning that FECO surgery and in the bag implantation of the IOLs. So if the
Yeah.
I'm not good. I mean, I'm
I,
not
my
audible.
no, it's a problem at my end. My AirPods are working alternately,
Okay.
so I had to shift them.
Okay.
Yes, sir.
Okay, my question is like on the nasal side, if the subluxation is more than 6 clock hours, even up to 7, 8 clock hours, also we are planning the surgery in a way to implant the IOL in the bag. So if the subluxation is on the temporal side, so is there anything like the extent of subluxation? The choice will get will be different with the number of clock hours involvement. A lesser number of clock hours will be preferable rather than more number of clock hours. That's what I wanted to ask compared to
No,
the nasal
sir.
side.
No, sir. If I am planning a CONI for 6 clock hour nasal, I'll do the same plan for 6 clock hour temporal. The change may be in the ease of maybe using a segment rather than a CONI fixation, or maybe using both a segment and a CONI. If I anticipate that it is not going to take care of the one device, one point fixation is not going to take care of the entire extent. So that may be there, but otherwise the surgical plan does not change from maybe a back fixation to a intralenticular lens aspiration or ICC. That is not affected. The number of points of fixation may change on how
Thank
the
you.
surgery goes. If it remains the same, if it's six there, then yes. But if I manage to extend it and drop, then a 2 point fixation maybe. Yes, sir.
I
Dr.
think Dr.
Sridevi,
Siri had a
yeah,
Yeah.
Dr. Siri had a question. Yeah.
Ma'am, regarding the flags, the incisions that are made in the femtosecond laser system is quite anterior. So do we still prefer to use the incisions that were made that are made with the help of femtosecond, or we prefer to make it with the help of the blade?
So it depends on the machine. Femtosecond laser platforms are notorious for having anterior incisions that do not open as well. Of the various platforms, no financial disclosure, Lensex is the best. So this one was Lensex, in which you can go relatively posterior. The other platforms I have now experience with Catalyst as well and Lensar as well. I will not prefer to make an incision. I will use a microkeratome. However, with Lensex, I would still prefer a femtosecond incision. Depends on the machine I have.
Okay.
Jayanand, you also had a query. You will have to unmute yourself. Yeah. No. Yeah.
Ma'am, I have a question. Does that femtosecond works when there is a vitreous in AC? I mean, you have
Yes, it does. It works
it.
beautifully. We have done multiple cases. The cavitation bubbles get enmeshed in vitreous. So the additional advantage is you highlight the vitreous using triamcinolone. Now your cavitation bubbles are stuck in vitreous. You as it is can see where the vitreous is, even without triamcinolones. So
Okay.
anything that is there in the anterior chamber, the cavitation bubbles are going to get stuck to that. I'll send you the video across as well, or you can watch it again. If you can see, whenever the moment the bubbles were being released, they were all getting enmeshed in the vitreous gel that was there in the anterior chamber.
Okay.
So any optically clear thing, maybe a vitreous, maybe a phakic, it's not going to impede laser delivery. It is just going to entrap the cavitation bubbles.
Okay. And second question I have, ma'am. Usually, it is said that in a femtosecond, the Rex's strength is slightly, I mean, weaker compared to the manual one. So, did you feel any time putting the CTR or the segment CONI, it got extended or something like that?
No, but one change we do in femtosecond is the aggressive polishing that we do of the anterior capsular edge that we avoid, because during that we have seen extension of the anterior capsule. In a subluxated case, I'll take care not to do a aggressive polishing of the capsular rim, anterior capsular rim.
Okay, okay. Thank you, ma'am. Thank you.
I think we have had a very fruitful webinar. We have 12 minutes more. We are ahead of schedule. So any tips from the experts I would like to know? The tips which are not written in the books or the little manuals that we learn along the way when doing multiple subluxation. Like I said, now I prefer putting hooks by passing a Sioni or a capsular tension ring in larger extent of subluxation. So any such tips, sir? Rama, sir?
Nothing specific. Yeah, yes, regarding that vitreous in AC with subluxation, like every time being a basically a vitreous surgeon, I have more inclination about cautioning about that particular part. So one should be very careful about not causing traction in the posterior segment. So one should be careful in clearing the vitreous properly before, as you mentioned, expert hands are always better in that. So with the surgery, Tityal sir's surgery, if you watch, you feel like everything is so easy. So one should be very careful. So I just want to caution about that. And yeah, nothing from my side. I think comprehensively covered webinar.
Dr. Vijay?
I think we had a thorough discussion. Most of points are covered. I am also not able to find any point which further we can reinforce. I think most of points are covered, in my opinion. So, yeah.
Dr. Sridevi?
So I think it was a great webinar, and got to learn a lot of new things today. And thanks to all our panel and experts. So it was really great. I just had one query. So recently I had a case. It was I just remembered now. So she was an 85-year-old female with a very hard NS grade 6 cataract, and so preoperatively we did not note any subluxation. So it was a polydilating pupil. And intraoperatively, during the phaco, once the phacoemulsification started, we saw that the lens started tilting towards the vitreous cavity. So, and so much so that, more than 180 degree of the lens was tilting down. So in such a scenario, what would the, approach of the house be like? Would you think of delivering it? Would you try to salvage the bag by putting hooks? Or, so what is our, kind of a cutoff that where do we stop trying to salvage the bag and just...
Before we need to call Dr. Rama.
So that was my approach, because I really thought that I spent 10 more seconds on that case and I would be calling Dr. Rama. So that was precisely my approach.
86 years itself is something which is like where you should not proceed further, because we know that is going to give way afterwards. So it is going to give you if you continue with that. So you should take a call early.
Yes, so I delivered, but I was just wondering, was I too aggressive in delivering, and probably should have tried some of these maneuvers that we saw today.
No, I think in such a scenario already, I think half or more than 6 o'clock hour subluxation, it's tilting. It's better to take it out as early as possible. Just enlarge the incision and take it out. Yeah. Better option.
Another approach is, in a lot of these cases, I have put hooks to stabilize the bag and gone ahead with a phaco. 86-year-old, I will also be very wary, because as it is, their zonules are so weak and the nucleus is generally so hard that it's difficult to get away with it. But in 60, 70 and even 80 years old, I have done it and then maybe left a phakic. The only advantage is avoiding a large incision and then maybe doing a secondary intraocular lens later on. And once you remove the hooks, if that bag is salvageable or not. And if it crumples, that you have to take out the bag. The only advantage of doing the phaco in the bag is a small incision and minimal vitreous manipulation. That said, there is a risk that once the rexus extends, just in case your hook extends the rexus, it is going to fall, because the vitreous is going to be liquefied. So you have to be very alert throughout the surgery, that you may need to convert and be extremely ready at all times, that you may not get a chance, because once it starts falling, you cannot do anything. It will be so rapid as well. So it's a very fine line. The older the patient, the more challenging it is. but you can
Yes.
try with the knowledge that even despite all your hard work, you may not be able to put a lens in the bag.
Yes.
Any famous last words before we break up for dinner? Okay, thank you so much everyone for joining and sparing 2 hours.
I think we
And
should also thank Dr. Manpreet for organizing such
Yeah.
a wonderful webinar and
Thank you.
conducting it so beautifully. It was really
I too
great.
converted it into a RPC alumni because in
Yeah,
challenging cases, the whole your mind goes to your seniors, people you have seen who have the expertise, because everyone can do a phaco, but everyone cannot do a phaco in subluxation well. So thank you for consenting. I know we are in the overexposure era, and it's really most of you want to say no to sitting 2 hours in front of a screen, but I think this will be very useful for everyone watching. Thank you so much.
Thank you.
Thank you.
Thank you so much,
Thank you.
ma'am.
Good night. Good night.
Thank you.